Hi folks, welcome back to the Reading Room. I'm Ryan, and this is the series where we go through common or at least interesting cases in small animal practice, discuss the radiographic findings to help you improve your veterinary practice day to day. So today we're actually going to take a deep dive into a really cool topic, I think, which is migrating wire foreign bodies. And so some of you may have actually encountered these previously in your practice. They look a little something like this. You've got this wire oftentimes in the abdomen, and the question that we often have clinically is, what does this mean and what should we be doing about it? And that's exactly what we're going to talk about today. So in this case, I put forth on our Weekend Rounds newsletter, weekend-rounds.beehive.com. Be sure to sign up to get early access to these cases. I put forth the question to the OB community, all right, what is the location of this foreign body? So we can all see it. It's this nice, bright white metal opacity in the abdomen, but where is it actually located? And this is an example where it's, really divided on where people thought it was. So some folks thought it was in the stomach, some folks in the peritoneal space, and others in the small intestine. And I really think this is a great example of why these are such a challenging diagnostic in clinical practice, is sometimes it's very difficult to tell where they actually are. So in this instance, what I think is actually happening is that this has migrated at least partially into the peritoneal space. And the thing that's telling me that is the cranial aspect of the wire. So the more caudal aspect here really looks like it's superimposed with this intestinal segment. We can kind of trace one margin of the intestinal segment here and another margin somewhere over here. You can kind of see the intestine turning there. But then there's this additional part which I'm not convinced is really in the intestine in any of the available images. If we go back to that first one again, we can kind of look at this cranial margin here. Again, not sure that that's actually within any of the intestine as we look at the margin kind of coming down and around here, I should say. So that's something that I really think we need to pay very close attention to. If you didn't zoom up on the image, you might be, convinced that this is in the small intestine. No one said colon, which is great. The colon should be kind of sitting more dorsally up here. A couple people said stomach, which, I think the caudal margin of the stomach is located here. So really no reason why we should be thinking it's stomach at this point. So the question then becomes, is this small intestinal or is this in the peritoneal space? And this is where we can kind of look to some of the literature to suggest to us what is most common and where we actually see these cases in most cases. If we're looking for this in the VD projection, we can see it here. And again, it's not definitively in any one location. This could be small intestinal or it could be within the peritoneal space. So migrating wire foreign bodies are pretty common in practice. They're mostly incidental, and we actually don't have a ton of literature on them. What we do see in the literature is a couple case reports. There's the small intestinal intramural hematoma secondary to a migrating wire foreign body in a dog. This is from a group out of NC State, and they looked at this patient that has a huge number of these, right? They're kind of like all over the abdomen here, these wire foreign bodies. And what they ended up finding was that these wires migrated into the wall of the small intestine, caused an intramural hematoma, which caused this widening of some of the intestinal segments, which they're pointing at here with the arrowheads. And this is what actually caused the clinical signs and obstruction in this patient. The same group looked at a larger subset of patients with wire foreign bodies. So this has not undergone peer review yet. This was published in abstracts of 2019 at the ACVR conference. They looked at 216 cases. Most of these were abdominal and only a couple in the thorax. And what they ended up finding was that 86% of the time these were incidental, and then they were possibly related to clinical signs in the other 14%, possibly related in 9 of those, suspected in 1.4%, and only confirmed to be associated with clinical signs in 3% of cases. That's a pretty good subset, over 200 patients with those wire foreign bodies, and again, not a huge ton of them are causing any clinical signs in our patients. There's also a report out of the group from UC Davis. They found a wire foreign body here in the cranial thorax, kind of migrating towards the axilla there, which caused intermittent lameness in this patient. And these are all examples where things can go wrong in these instances. So the question is, if we find these, what do we do about them? Well, I think the important thing to know is that 85% of the time, or thereabout, from that abstract from NC State, nothing. We don't really have to do anything. These are incidental findings. But sometimes they can be related to the issue, right? That's not a 0% chance that they're related. And then what we're looking for there is, do the clinical signs fit with the case? So could this be associated with the clinical signs in that patient? And can we find any other cause? If there's no other cause and the clinical signs fit well, then my recommendation is that patient should go for a CT. These features are way too small for us to find ultrasonographically, and while we can sometimes see some evidence of the changes, really these patients need a CT for diagnosis, for us to find the wire and identify it, and hopefully then be able to address it surgically. But most of the time that you see these wire foreign bodies in the abdomen, they're completely incidental. They're not much to worry about. We think they're from barbecue brush bristles. The patients eat them, they migrate out of the stomach, and for whatever reason, they don't end up causing much clinical sign. So I hope this has been helpful in these kind of interesting cases. We're kind of wrapping up barbecue season for the year, but you never know when a patient's going to present because the migration happens anytime. And so next time you see one of these in practice, you can think to yourself, there's an 85% chance that this does not matter. And on the off chance that it does, my next step should be CT. Hope that helps, and we'll see you next week for another great case.